Good evening, friends. So this year, again, we start a series of lectures by experts. Our first expert of the year is Dr. Sonam Solanki, young and dynamic Dr. Sonam Solanki, a pulmonologist, MBBS, DNB, several fellowships, observerships, and even at this young, tender age, she is attached to several hospitals. She is a consultant pulmonologist, Sefi Hospital, Bhati Hospital, Wokad Hospital, and Masina Hospital. She is a honorary consultant at Dr. Baba Saheb Ambedkar Hospital, Central Railway Hospital, and Jagjeevan Ram Hospital, Western Railway Hospital. She has tremendous skills, and it is always an endeavor of us to invite young doctors, young and dynamic doctors, when we are talking of updating our knowledge. So this first series is update in pulmonology, but largely restricted to airway disease, because we have spoken a lot on asthma and COPD. She'll be talking on whatever update has happened in airway disease management. Dr. Sonam, welcome. Please put on your video and audio and join us.
Thank you. Thank you, sir. Thank you for the kind introduction. And while I share my screen, is my screen visible?
Yeah, visible. Visible.
Yes, just a moment. Okay, so I think, yes, I have the pointer as well. So thank you, sir. And
the slides are appearing smaller.
Smaller? They are
So
not in full presentation.
Both, next animation and this we can, yeah, this is right.
This is better?
This is better. This is perfect, yeah.
Okay, fine. So I think the presenter view is not working well. No problem. I just wanted the pointer. Okay. So, yes, thank you, sir, for giving this platform. And I have, been introduced to sir by Dr. Aarti, and thank you to Dr. Aarti as well. Without, delaying further, I'll just, give a brief introduction on what we are going to discuss today. I've been told that you all have understood spirometry. The basics of spirometry is already taken care of. So what spirometry is used for? To diagnose, manage, treat airway and lung disease. And airway disease is a predominant, component of pulmonologists' treatment as well. I have tried to cover up asthma, COPD, and their updates. Some slides may seem complicated. That's why I want to give this disclaimer that I think I have kept that to explain certain concepts. So don't waste too much time really trying to decipher those busy slides. If there are, just concentrate on what I'm saying, because there is a point to how we want to go about. So what is the relevance to the audience today? The relevance is that, there have been multiple studies. If they have asked 100, seen 100 patients who come to a family physician's clinic, and if you see what is the commonest symptom that they come with, almost 45 to 50% patients go to their family doctors with respiratory symptoms. It is far more than the digestive, circulatory, and other systems, which is why the role of a family doctor in managing airway disease is very crucial. It is to identify chronic illness, asthma, COPD, ILD, tuberculosis. They will not suddenly come and say asthma. When you see these patients with frequent symptoms with seasonal change, these crackles that just don't go, that's when you think of ILD. When these cough and breathlessness and mucus production, these three main symptoms are associated with weight loss, with fever, or other risk factors, you think of tuberculosis. So identifying chronic illnesses is, I think, the onus of that is on the family physician. Guiding the appropriate patients to the specialist, regular follow-ups, and communicating with the specialist. These are chronic illnesses. So it's not that one time they visit the doctor, they start the treatment and they'll be all right. They are going to have periods of worsening, whether it, especially this rainy season, we know of, when they are having other illnesses. So I think family doctor's role is very crucial in staying in communication with the specialist as well. Identifying acute exacerbation and managing the mild worsenings. So we define exacerbation as any symptoms in a chronic, say, asthmatic patient or a COPD patient, in which there is increase in the symptoms that require additional treatment, be it in the form of antibiotics, be it in the form of steroids. For a few days, they take nebulizations at home, but any worsening of their pre-existing baseline symptom is known as an exacerbation. When it is mild, we can treat it on OPD basis with simple oral medication. A moderate to a severe one may require ICU hospitalization, and a moderate one will require a normal ward-based hospitalization or a back and forth, depending on the severity and the armamentarium that patients have at home. Visiting these patients at home is also very important. We have more and more patients on BiPAP. They're getting discharged from the ICU hospitals, and we've seen this during COVID with an oxygen, with a BiPAP. And that's where I think it's very important for the family doctor to be updated with the extreme end of the diseases. When I say diseases, respiratory airway disease can be divided as upper airway or lower airway. For the purpose of this talk, we are concentrating on the lower airway disease, predominantly asthma, COPD, bronchitis, emphysema, which is another phenotype of the COPD patients. So it's simple cartoon diagram. This is the airway, this is the heart, this is the lung. So these are the disease that we are talking about. When we talk about pneumonia, lung fibrosis, IPF, sarcoidosis, they are diseases of the lung parenchyma. When we talk about pulmonary hypertension, congestive cardiac failure, pulmonary edema, they are diseases of the circulation, pulmonary circulation. So this is how we divide amongst airway disease. As you can see, this is the anatomical, bifurcation of the airways. We in our physiological and anatomical classification go as per generation: first generation bronchus, second generation. Similarly, it's like a tree branching down, like the way you have branches of a tree, roots of a tree rather, and even branches, smaller and smaller airways as we go inside. And from the 8th generation onwards, when you have bronchioles, terminal bronchioles, respiratory bronchioles, alveolar ducts, alveolar sac. Now, why are they so important to identify? These are small airways. We define them less than 2 millimeter. They are very different in terms of the compositions. As you can see, these blue lines, these are the cartilaginous rings around the larger airways. There are no blue rings here. So there is no cartilage. That is the first thing. They collapse very easily. The flow over here is different. There is a turbulent flow up to this generation of airways, and it becomes a laminar flow when they go to the smaller airways. This is not just important in our anatomy class, but in physiology. Why it matters? Because inhaled medication that we use for diagnosing and treating the airway diseases, whether it's a powder-based inhaler, spray-based inhaler, nebulization, final bifurcation is particle size. So where there are particle size of the DPI, MDI, which is important. So we'll choose inhalers specific to this. The device and delivery system becomes very important when managing these airway diseases, and it's not routinely picked up in spirometry. So, I mean, I'm sure all of you all would have had the patient where, they have a seasonal symptoms, there is some history of allergy, constantly coughing, chest examination, there is no wheezing, because traditionally we have been taught that airway disease, asthma, COPD, that bilateral bronchi is there. We saw it during COVID. There were studies where that post-COVID cough just went with inhalers. We only had to give them either a home nebulization or inhalers, and that's only when the cough went, because it was all affecting smaller airways. You won't not get clinical signs in these patients. And even on routine spirometry, subtle changes of that FEF 2575 will be seen. If you do complete body box, you will see a lot of air trapping. These are indirect signs. And that's why we really need to look at small airways and we diagnose them differently. And so then if we know that the airway disease is predominantly small airways, we'll treat it a little differently. How? So this is the CT scan. CT scan has been very rampantly used, but if you really want to, I mean, and we know that X-ray and CT generally will always turn out to be normal in an asthma patient. But if you protocolize it, if there is a, so you tell the patients to take a CT with an inspiration, mid inspiration, and then a complete expiration. So what you get is, as you can see, these areas of gray and black in the same cut. So we call this as mosaic pattern. And of course, there is multiple differential diagnosis of it. Sometimes in chronic HP also you see it, but this predominantly is a marker that smaller airways are involved. And sometimes you can have a normal PFT, normal looking CT, and you'll only pick this up on an expiratory scan. Similarly, as you can see, this is, I mean, pardon me for a not very accurate, it's a little blurred, this diagram, but when you take standard inhalers, this is how it gets distributed in the larger and the mid airways. But when you have extra fine inhalers, and there are more and more extra fine formulations that are being developed. In India, we currently have one ICS LABA, which is an extra fine inhaler. You see that the distribution, all the blue area, so the inhaled medication reaches the smaller airways as well. So this entity of identifying small airway involvement in our airway disease patients is really revolutionizing the way we see it. We are with more, we all work in a metro city at least, so we don't have issues where PFT is not available. Most of our airway disease patients will have undergone a pulmonary function test. Still, there are some patients who are symptomatic, not getting picked up. So these are the things to keep in mind clinically. Now, asthma, what we know is that it's a heterogeneous disease characterized by chronic airflow limitation. Symptoms are cough, wheezing, chest tightness, shortness of breath. Variable airflow limitation, that is very pathognomic of when we say asthma. Even if you look at any of our histories, the symptoms are paroxysmal cough and breathlessness, or paroxysmal breathlessness means the patient is symptomatic and then okay for a while, then again symptomatic based on the triggers. Or you can have a perennial symptom also, someone is unwell all through the year. But this variability, that today the patient is okay, tomorrow when there is a trigger or they get exposed to dust, or during Diwali, we see a few of our patients where they suddenly become symptomatic during Diwali and we saw it in our winters this year where the AQI was bad and the patient became more symptomatic. So this variability in symptoms, and if you do PFT at that time, you will actually see that it's a normal PFT today, and when the patient is symptomatic and triggered, it's a moderate obstruction. So that is what we mean by variable airflow limitation. Typical of symptoms is nocturnal, at night, seasonal, associated triggers, and a positive family history. So things to identify here is two more slides on variable airflow limitation and associated triggers. Now, what are triggers? Anything where the patient is all right today, and after the exposure to a particular, whether it's an irritant, infection, pollution. So as you can see, animal fur, always ask for whether there are pets in the house or not. Cigarette smoke or wood indoor, wood chula in India, we see this. What sort of blankets are the patient using, pillows, weathers. The colds, running during sports, are they symptomatic during exercises? Very important at family physician level, drugs, emotion, if something has some fight in the house has triggered the symptoms. These are very important things to identify. Now, this diagram really can, I'm going to spend 40 seconds on this slide because it is very important. It almost summarizes what we are seeing with our asthma patient. As you can see, this airway, these are the tube, this is the airway wall, this is the airway lumen, and these dark brown stripes are the smooth muscles which we can see around the airways. What is happening when the patient is in an attack? You can see the airway wall has thickened, the lumen has reduced. You will also see mucus over here, and there is a spasm of the small airway. So you can imagine what the patient feels, right? Like someone is choking them. And this typically they feel that there is a voice when they expire. So what we typically ask the patient is that, is there wheezing that you experience? Is there whistling sound that comes from your chest? And these are very classical of a severe asthma attack. You will not see this in always in mild attack. And what is also important, that each patient may not have the component of all three. So when you have extra exercise induced bronchospasm, only smooth muscles are hyperreacting. You can have a component where there's not too much of smooth muscle spasm, but airway inflammation is there. Especially if someone is genetically predisposed to have asthma and start smoking. So they may not always have spasm, but they will have airway inflammation. So the take home from this slide is three things I want you all to remember: airway inflammation, mucus hypersecretion, and smooth muscle contraction. Because airway disease predominantly boils down to these three components when it comes to pathophysiology. Now, how do you measure airflow limitation? This is the spirometer. And I know a lot of you all have a handheld spirometer in your clinic, which is also fine, but this is how a set system looks like in the hospital. This is a peak flow meter. It's, I think, one of the most underutilized device when it comes to managing asthma. Patients can buy it once in their life, and actually it suffices them for their whole life. And whether they have seasonal variation, whether they are traveling somewhere, there is a lot you can do with this simple device. And most of our patients, we recommend them to have this device. And when they come to for follow-up, they share the reading. It's like the equivalent of a glucometer for your diabetic patients. Most diabetes patients will have a glucometer at home, although we don't see the case in asthma, where most asthma patients do not have a peak flow meter, but the utility is to that effect. And this is how a body box looks like, but this is mainly for lung volumes and diffusion. So for airflow, these two are the devices that we use to measure out. And this is how a simple spirometry looks like.
In, out. In, out. In, out. Now take a deep inhale.
Notice
First
this.
clear. Out, 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 out. Take a deep inhale.
So, of course, you all have already gone through this, but I wanted to just show you that it is such an effort dependent test, spirometry. Minimum 6 seconds you need to expire. Children cannot perform it very often, and very extreme of ages, of course, very elderly patients and people who have very severe disease cannot perform it, because it's a forced expiratory maneuver. You have to take a deep breath in and keep on blowing out into the device for about 6 seconds. Which is why when the update in the diagnostics of airway diseases, that there are two additional things that we do, and which is now available. These were theoretical things, but these devices were not widely used, but you will see more and more pulmonologists using these devices. FeNO is a fraction of exhaled nitric oxide. It correlates with airway inflammation. And here also, it's not a forced expiratory maneuver. You just have to blow into a device, but at a fixed rate. You have to just maintain the flow rate in which you blow. There is a sensor at the end which measures the nitric oxide that is coming from the expired air. And airway inflammation, if the airway inflammation is high, the FeNO will be high. When it is low, it will be controlled. Similarly, FO2, FOT or IOS, that is impulse oscillometer or forced oscillometry technique. So these are basically just devices. It's a separate topic in itself. I'm not going to go in the detail, but what we need to know is that these devices do not need a forced expiration. So the patient can just breathe in at tidal breaths, and the machine keeps sending vibrations and measure airway resistance and flow. And you give the bronchodilator and repeat the test again, and it sees how much resistance has reduced. So these are the two new things that we do to assess patients with airway obstruction. Now, what we know that asthma is genetic. There's persistent and intermittent symptoms. They worse with some triggers. Inhaled medications are better. Gone are the days where whether it's a guideline or whether you see our standard of practice, unless it's an emergency, we would give the steroids, but gone are the day where your Derifilin, tablet Astalin, and all were given routinely. Controllers are as important as reliever, and ICS is as important as SABA. Now, building up on this, what I mean when I say reliever and controller medication, reliever is it's a bronchodilator, quickly relieves symptoms, rapid onset of action, short duration of action, to be used as and when needed. And a controller medication is an anti-inflammatory, prevent asthma symptoms and attack, may have delayed onset of action, long acting, and to be used on regular basis. Very often we see patients for, like, I saw somebody this week, asthmatic she's 34, came in with a severe exacerbation, came to the ER, took steroids 2 times. And when I asked her, okay, she knows she's asthmatic, but she's been taking her MDI Astalin for the last 15 years, and has sometime 15 years ago, someone must have diagnosed and not gone to the family doctor, not gone to a specialist. And the treatment has drastically changed in the last 15 years. And we would no longer give the plain Astalin inhaler also to our patients, because we have now understood that along with the bronchodilation, targeting the inflammation is also important. So I'll spend a few slides on inhaled therapy, which is going to be common for asthma and COPD both. But in the sequence in which we introduced the molecules is important. So short acting, long acting, or ultra long acting LABA, that is beta agonist. Short acting, long acting, ultra long acting antimuscarinic, or the LAMAs, and inhaled steroid. These are the 3 components when it comes to in whatever molecule you're giving, whether you're giving nebulized. These are the 3 main things that we are giving, whether now that's short acting, long acting, ultra long acting. And we are spoiled with the number of devices and number of molecules we have now. It's just about identifying the right patient and giving the right inhaler, right molecule to the right patients as per their requirement. So beta agonist causes bronchodilation. You can see this is a normal airway. When there is an attack, you give the beta agonist, whether it is salbutamol, levosalbutamol, or formoterol, salmeterol, indacaterol. These are once a day, 24 hours acting bronchodilator. The airway inflammation is the same, but the smooth muscle has relaxed. Similarly, antimuscarinic, the LAMAs, whether it's ipratropium, short acting, tiotropium, 24 hours, glycopyrronium, based on the dose, it will be once a day or twice a day, and umeclidinium, it is once a day inhaler. But predominantly what they are doing, they are causing bronchodilation and mucus, reducing the mucus production. So because all these yellow dots are where the antimuscarinic receptors are there, and this sort of blocks it. Airway smooth muscle, the vagal tone of the airways improves, reduces, so there's bronchodilation and some effect on mucus hypersecretion also. What does inhaled steroid does? Again, whether it's beclomethasone, budesonide, fluticasone, cyclisonide, mometazone. So each steroid has its own property, but in the end, they are all the steroid component of the inhaler. It reduces the inflammation, opens up the airways. Again, can affect the mucus production also. Of course, this will not work on the smooth muscle. That's why in mild disease where it's only inflammation, you can do away with only giving the steroids. But when there is bronchospasm also, you need to give the steroid along with the bronchodilator. Now, what are the things that we've realized? 5 years back, what we knew and what we know now is that MART therapy is also good enough. What is MART therapy? It's a maintenance and reliever therapy. So in a single inhaler, you have the long-acting bronchodilator and the inhaled steroid. You identify inflammation is also equally important. Now we have newer drugs, like I just showed you. We have newer devices, like I'm sure you all see this in the market. You have breath actuated devices, MDI with spacer, but device is a completely different topic in itself. And, for the interest of time, I have not covered that. And the most important and the paradigm shifting, identification in asthma management is that even if you do everything correctly, there are 5% of the patient who are innately severe, and we call them severe asthmatic. It's not because of what they're doing. It's not because they didn't take the inhaler. It's not because, after you do all of it correctly, there are some patients who are bad. And I'm sure you all see this in your routine practice. This is the single maintenance and reliever therapy, formoterol and steroid. Whether it's budesonide or beclomethasone, whatever. Formoterol, why specifically formoterol? Because it has a faster mechanism of action. So when the patient takes it, in 30 minutes, they will feel the bronchodilation. Whereas in salmeterol, the peak occurs in 3 hours. So it's as good as the patient taking, say, an Astelin or a Duolin, where they walk around with it because they feel immediately better. The equivalent is, say, a sorbitrate for an angina patient. So bronchodilation and anti-inflammation, both in the single inhaler. So there is a fixed dose that we give the patient, and whenever the patient is extra symptomatic, we tell them to take the additional dose of the same inhaler. Again, this is one of the slides where I said, don't worry, we are not going to go through the whole thing. But what is important, I want you all to understand, is that there are steps. Okay, so if the person is mild, you give them low dose ICS plus formoterol. If the person has more symptoms, less control, you go to a maintenance. So here it's only as and when needed. Take it when you're symptomatic. Patients are really happy because nobody wants to be dependent on inhalers or want to take it forever. But when you have more frequent symptoms, take the low dose maintenance ICS formoterol twice a day. And whenever you need it, take it as a reliever also. Step 4, you go to medium dose ICS if the patient is still symptomatic, or where the patient has daily symptoms, waking up with asthma. So we have our ways to assess whether this is a mild, moderate, intermittent, or regular treatment is going to be required. And when the patient, if the patient is already on a moderate dose, still exacerbating, frequently require oral corticosteroids, or there are patients who are on that, Visalone tablet, Defcort tablet every day, or they say that, oh, we cannot leave the house without this tablet, or they're getting hospitalized every time. And what they do in hospital, put them on nebulization, give them IV steroids. So people who need steroids very often, or are dependent on steroid, or the moment you reduce the steroid, they become uncontrolled. These are the patients who need step 5 treatment, where you're already on a high dose ICS LABA. You can add a LAMA also. You can add the other, your theophylline, your leukotriene inhibitors, Montelukast, cetirizine. And the main thing is the biologic treatment, which is the new thing in asthma management. Again, another thing I want you all to understand is that ICS and LABA is the mainstay of asthma treatment, which is not the case in COPD. We will see that in subsequent slides. Now, severe asthma, we know that many patients are not controlled, but very often they're not controlled because they are not diagnosed correctly. Along with asthma, they have a cardiac component not addressed, so address that. Along with asthma, they have reflux not addressed. Please address that. Along with asthma, they have 40% patient will have allergic rhinitis also. So they'll say that, oh, I'm not breathless, but I still cough. So address all these comorbidities. They are smoking. Smoking cessation has to do. So you do all of it. But still, by definition, if the patient is taking treatment, still there will be 5% patient who are severe asthma, uncontrolled despite maximum treatment. You need to identify what is driving the inflammation in these patients and give them targeted therapy. What is targeted therapy or biologic therapy? It is not something new in rheumatology. Even in India, we've been using this. Rheumatologists have been using it for decades. In cancer, there's immunotherapy. You identify what inflammatory pathway is active, and there are molecules which target those inflammatory therapy. What is in general important to understand is that they are add-on therapies. So your patient will take the inhaler, or everything continues. You're just adding the biologic treatment. They're injections. Only one molecule so far is IV. Rest all are subcutaneous to be taken like in insulin. They block a particular cytokine or alarmin in the inflammatory pathway. They reduce exacerbation. They reduce the need for oral steroids. This is the two things that we used to talk about 5 years ago when we only had one biologic molecule. But now with more data and more upstream targeting of the inflammation, these molecules can also improve lung function and quality of life. there is no endpoint to treatment. They have to take this. See, we tell them to commit to at least 1 year of treatment if they are such severe asthmatic, and then take it from there, whether who needs it, whether we can reduce the dose, things like that. And well-selected patients, and if they are adequately treated, they can actually go in remission. Whereas remission is something that was never discussed. Imagine having a disease-free life on treatment, but a disease-free life, or an exacerbation or a symptom-free life. And that is completely transformational for the patient as well. What are the approved biologics? Not going in detail, but omalizumab, which is anti-IgE, mepo, benra, reslizumab, anti-IL-5, dupi, which is anti-IL-4, and tezepelumab is anti-TSLP. These, no need to remember this, but I only want you all to, these are the only 3 currently available in India. Again, no need to remember this diagram, but what I want you to understand is that we keep saying, patients keep saying that I do everything well, I don't smoke, still I'm getting these triggers and symptoms. Because what is important to identify that the way there is allergens that trigger the airway, this is the epithelium. There is pollution that triggers, there's microbes that trigger, there is irritants that trigger, somebody staying in close to an industrial area. So it's so multifactorial, the trigger to our patients with airway disease, that even if you control one, so very often I get patients, they read it somewhere, they're like, oh, this is allergic, okay, let me do an allergy test, let me do allergen immunotherapy, will that be okay, will I stop exacerbating? The answer is probably not always. It will depend that if only one allergen is a trigger for you or not. And if you have these other components which are triggering your asthma, we may not. So the important areas are goblet cells, again important even in asthma. When whatever triggers, this is the first line of defense is these macrophage, IL-5, and these alarmins. The first line of defense is the alarmins. Then there is a cascade of inflammation, IgE mediated. What is more and more recognized that all asthma is not just IgE mediated, only a small percentage which are atopic and eosinophilic mediated asthma. But there is a non-atopic asthma also. So these are patients who probably don't have a family history, who are obesity related, middle-aged females. It's very common in them. And the inflammatory cascade is completely different. There is nothing to do in IgE it's not got anything to do with IgE. And they are triggered by IL-5, IL-4, IL-13. So this is important to identify. And when it comes to biologic, anti-IgE, that is omalizumab, they target anti-eosinophil. So the 3 molecules we spoke about, that benralizumab, mepolizumab, reslizumab. Then there is anti-IL-4, because if you block IL-4, automatically 13 and 5 both get blocked. So more and more symptoms. So nasal polyposis patients where IL-13 has been identified to be, and we know that nasal polyps patient, even after surgery, there is a chance of recurrence. So eventually we will be able to offer these molecules to them as well. And lastly, anti-TSLP. This means the upstreaming. So this is upstream to downstream that happens. And these are the molecules: omalizumab, mepo-benra, resli, dupi, and tezepelumab. And this is just conceptually, I want the audience to understand this. Now, the struggle with airway disease is, mild. They're like, I don't want to be on inhaler. Adherence to inhaler is a big problem. Incorrect technique, mistakes while taking the inhaler, preferring oral tablets. Severe asthma, continue to take oral tablets. The cost of biologics, because these are all expensive molecules. Nebulization, and the SOS, go to the family doctor, go to the emergency department and take an injection. So I won't emphasize more, but we know this, that intermittent and continuous steroids, oral steroids, systemic steroids are associated with cerebrovascular, heart failure, diabetes, cataract, fracture, osteoporosis, so many issues. That's why steroid sparing, these biologics are steroid sparing, and it becomes very important. And this is the question we need to ask ourselves and then explain to our patients, that what is more important to treat? Is it important that all our resources go in treating blindness, or it's better to control your diabetes better? Is it important to treat CKD or control? Do we want more kidney transplants, or you want a better diabetes control? Definitely better diabetes control. What do you want? Extremely high end quality of care for diabetic foot, or just control your diabetes better? Similarly, do we want deformed joints, or identify the disease in the inflammatory arthritis period so that you prevent deformities? What is better to target and treat, cirrhosis or fatty liver? So it's the same analogy when it comes to airway disease. And this is very important to understand. And these next two diagrams are from real life biopsy specimen of patients who were inadequately treated, or what we call it remodeled asthma, where the asthma almost behaves like COPD, where it's an irreparable damage to the airways. Need not go in the details, but can you see these transparent white dots? These are goblet cells. So we have goblet cell hyperplasia. Can you see these smooth muscles? These are smooth muscle hyperplasia. Can you see this extremely pink color? So these are the alveoli here, vasculature here, and there is subepithelial and endothelial fibrosis. So fibrosis, smooth muscle hypertrophy, and hyperplasia of the airways, and permanently damaging. And then when you give them, they're on home nebulization, are not better. They need steroid, then steroid related complications, and there's like a cycle that happens. So I tell young patients very often, and parents also, that instead of being in the denial of the disease, identify the severity, try to minimize how much medication you need, but don't stop medication, because there is a long-term consequence to that. Very often these home BiPAP patient, type 2 failure, where carbon dioxide is there, a lot of them are remodeled and severe asthmatics. And to summarize the current management and future when it comes to asthma treatment, allergen goes to antigen presenting cells, which go to T2 cells. There is cytokine, blah, blah, blah. There is inflammatory thing, whether it's eosinophil, mast cell, basophil, and these are the small granules. And they degranulate, and that's when you have the inflammatory mediators release. What we do when we give inhalers and the montelukast and the derifilin, etc., we working at this level. So after the release of inflammatory cytokines, they go to the airways, they cause swelling, they cause spasm. And pharmacotherapy, we do this routinely. This is what doctors are doing. What we ask our patients to do is identify the allergen. Kisse hota hai? Do you eat something and it happens? Do you, there is a particular agarbatti that you have, a particular perfume that you have, avoid the allergen. This is what we ask our patients to do. In some cases, mild disease, if we know that only house dust mite is causing the triggers, and we can give immunotherapy, desensitize the patient to that particular allergen. But the future is here, where you identify that what is really causing the trigger in the patient and target it at that level. And this is almost like targeting the deformity and not the inflammation, which is a big paradigm shift when it comes to airway management. Again, no need to read all this. I just want to say that this is the airways inflammation, but this is what we are targeting: hyperresponsiveness, remodeling, mucus production, smooth muscle constriction, hypertrophy. So all our efforts, yours and mine, have been at this level, but we are identifying the importance of this cascade here, identifying which cascade is most hyperreactive in our patient, and targeting this treatment. Now, this is common vaccination, allergy testing, nebulization. If there are any questions related to this, we will take it in the Q&A, but I will move forward in the presentation, moving from asthma to COPD. So are they the same thing? Commonly, there is a 10% patient which have an overlap, we agree. But otherwise, COPD is predominantly neutrophil mediated disease, whereas asthma is eosinophil and IgE mediated. Airway hyperreactivity is there. There is no airway hyperreactivity. So a COPD patient is symptomatic, will stay symptomatic most of the time, but there will be worsening. But it will never be that the COPD patient is all right and suddenly has an attack. Whereas in an asthma patient, they'll be all right today, season change, will come down wheezing and not even able to walk, one flight of stairs. Not much in PFTs, you will not see a bronchodilator response, whereas you will see a bronchodilator response in asthma patient, and not corticosteroid responsive generally. And there is a significant corticosteroid response in the asthma patients. What is different is that for the longest time, we've told our patients who were smokers, and okay, if you smoke, there will be COPD, which is true, but it's not the other way around. If you have COPD, does not mean that the patient has always been a smoker. We have identified that there are genetic factors, alpha-1 antitrypsin deficiency, other genetic variation causing COPD. People may have early life events, severe pneumonia in childhood, especially RSV, herpes, viral bronchitis can eventually slow growing lung. We can have, for the age the lung function is inappropriate, premature birth, they can have COPD. Cigarette smoke is just a part of the COPD etiologies that we are coming to know. And it's not just cigarette smoke. We're going to see more and more of this vaping, the hookah smoking, cannabis, exposure to in utero and passive smoking also is important. Indian household, indoor air pollution, whether it is the incense sticks for the dhoop that we do, the havans that are conducted in indoors, patients, the biomass, the chulas that women use in the villages, the cow dung cakes that are used as, so all of them are contributing factor to COPD. Asthma COPD overlap as well, and COPD of unknown origin is also important. Now, the way the etiology is different. Again, I'm not going to go over this slide, but the pathology, just look at even if you read the name, there is no mention of IL-5, there is no mention of IL-13. So completely different inflammatory pathways. There is bacteria, this is the epithelium, completely different, not a single common. Of course, there is this, there is a neutrophilic predominant asthma also. This Th17 is common, but it's a predominantly Th1 mediated disease. It causes fibrosis, alveolar wall destruction, mucus hypersecretion. So yes, there is some commonality, but they are completely different things. The cough that comes out in an asthma patient and COPD patient is also different. And in the next few years, this probably will be in the next update. We're targeting the mucus, understanding the type of mucus that the patient has will also determine the disease. As you can see, the asthma cough does not have too much of, DNA, actin. It's just proteins and mucin mediated, whereas the COPD one is it has more bacteria, actin, DNA, and a cystic fibrosis, where again a different topic altogether. But the problem here is a gene which is very important, and the mucus becomes very thick. There's a lot of bacteria, a lot of DNA, a lot of actin and mucin. So even the mucus between asthma and COPD patient is different. And the pathology wise, this is the hyperinflation that are not, and this hyperinflation we see in an X-ray also. And when we do CT of these patients, there is emphysema, air sacs, literally holes in the airways that we see. And this is what it looks like. There is large pockets of air which are then picked up in the CT also. And this is how the way you see in asthma, we had categorized them as stepwise, depending on the symptoms, the type of medication we needed. Here, you are categorizing them based on lung function, exacerbation, A, B, C, D. Earlier, we used to have C and D, but now there is E. What is important is how many times they exacerbate and how much symptoms they have. Drug-wise, it looks the same, right? Levosalbutamol. So again, components are three: bronchodilator, antimuscarinic, and inhaled steroid. But what is important is that in group A, you'll only have so mildly symptomatic, not exacerbating COPD. There's only bronchodilator. There's a long-acting LABA-LAMA combination in group B. You'll try and maintain the group E, and frequently exacerbating and symptomatic patients also. Consider the ICS only if the blood eosinophil is more than 300, where you feel that there is some role of anti-inflammatory also. But if the patient is predominant dyspnea, there will be, switch over the devices, go for the longer acting molecule that you have. But if the patient is exacerbating, there will be a role of inhaled steroid also. And then if the patient is a smoker, former smoker, you'll try the azithromycin, and or there is chronic bronchitis predominant, there will be rofumilast. Sorry, this molecule was available. It was a good molecule, but it's not there. It's been out of the market for a while. And unlike asthma, of course, the non-pharmacological methods are also important in asthma, but it is of utmost importance in our COPD patient, where we want them to have smoking cessation, a lot of physical activity. Pulmonary rehab is a big and underutilized tool when it comes to COPD management. Make sure that they are updated with their vaccines also. And other along with these non-pharmacological, there are surgical. The way you had biologics for asthma, the biologics are being studied in COPD also, but only in the component of COPD patient where inflammation has been documented, whether it's in the form of asthma COPD overlap, whether it's because the COPD patients has high FeNO also, or whether the patient has a high blood eosinophil counts frequently exacerbating. Some trials of biologics in COPD also, but otherwise it is such a mechanical thing. You want the lung volume reduction to happen. Not routinely happening in India, but there are endobronchial valve, surgical lung volume reduction surgery, and it all depends on the CT, whether there is, heterogeneity, upper lobe predominant, and which is why for severe disease patients, I would get CT done from a center which is able to understand and is able to give me these reports, whether what you mean by CV is the collateral ventilation they have to identify. FI means fissural integrity, because these are the things on basis of which I will identify whether a particular patient of severe COPD will benefit from a surgical intervention or not. And this is where I think assistance of family physician is very important. Home rehabilitation, home nebulization, whenever they come, you have to, these tick box have to happen, whether they're using it correctly or not, adult vaccination, home oxygen, home BiPAP. These are the important factors. So to summarize, I think early diagnosis is important, but it's equally important to understand the inflammatory pathways which is causing the disease in our patients. Irrespective of the ideal treatment, 5 to 10% of asthma patients will have severe disease. So it's imperative that we identify them, work them up for the phenotype and give targeted therapy to them. Short-term and long-term steroids should not be acceptable for our asthma patients. Do not give steroid to COPD unless they are phenotype and identified, or even during exacerbation, but for a short duration of time. And optimize the non-pharmacological intervention in our COPD patient. Disease is not just limited to airways, it is also the systemic inflammation. So you have to address their osteoporosis, depression, GERD, nutrition, all these components as well. And with this, I would thank the audience and everybody for a patient listening. These are the ways to get in touch. And I think we can move to our Q&A, and I'll be happy to take questions if any.
Thank you very much, Dr. Sonam, for a very lucid presentation. I have two questions. One is from Dr. Ravindra. In a patient of asthma and or COPD, can we use injection diclofenac?
Yes, so NSAIDs are one of those diseases which are with caution. So if you do not have any, it's not that every patient of asthma, if you give them an IV diclofenac, they will have a reaction, but it is one of those diseases which we want to avoid. So if you have the choice of giving any other molecules, it's better to give that rather than a diclofenac. COPD can be used, not necessary that it will always cause a bronchospasm. Aspirin, similarly.
Yeah. Sorry, go ahead. Please go ahead.
Yeah, aspirin, beta blockers, these are the other group of medication that you want to be careful with your asthma and COPD patients.
His other question is glycopyrrolate specific for asthma?
So
Sorry, specific for COPD.
COPD. So glycopyrrolate is a LAMA, long acting antimuscarinic. So yes, it would be introduced sooner in a COPD patient and only later in an asthma patient where you've optimized the inhaled steroid and bronchodilator component of your treatment and still the patient is not controlled, then it will be worthwhile adding the LAMA as well. But first line in COPD patients.
Then Dr. Leena Chopra is asking, is it advisable to do allergy testing in 4 to 5-year-old kids? Because a lot of patients nowadays want to do allergy testing.
Right. So briefly on allergy tests, so there are two things. One are the blood allergy test, the RAST. There is something called FADIA-TOP available in the market where they have taken they've just taken common pool of allergens in that area and made a kit out of it. And they are blood based. They are not very specific. Still, the standard would be a skin prick test. With children really depends. If they're having mild to moderate symptoms, or if they're having trigger, I would do it. Otherwise, it's not contraindicated, but you're pricking the child for so many things. And now when you talk to the adult, there are 50 pricks. You'll have to narrow down whether you want aero allergen, whether you want food allergen. And as per the international recommendation, it is not always recommended. Only if you're having really life-threatening worsening, and you know that today the patient is better, tomorrow is such a severe thing, kuch to trigger hai, that's when you try to identify. But I do not do it routinely at the request of the patient, because I know they think that allergy hai, let me identify what is the allergen and avoid it. Because if you are allergic to 6 things, what are you going to do? It doesn't change your management at all.
Dr. Nimi Torani is asking, can we advise, role of pranayam in respiratory disorders?
So it is very well established, more in COPD patients, because the diaphragmatic functioning, etc. And you want, one of the key things that I tell patients, and I think most of us, that the pattern should be that if you're inhaling for 5 seconds, breath hold for 6 to 7 seconds, and exhale for 8 seconds. So your expiration has to be more prolonged than your inspiration. That is the key message that you have to give. It may not, unless it's remodeled asthma, it will not affect so much in your asthmatic patients. It's not contraindicated. They can do it. There are multiple benefits other than just the pulmonary diagnosis of pranayam. So it's not contraindicated, but it will be of very much help to your COPD patients and ILD patients also, upper body exercises and breathing exercises.
Can we advise exercise to asthma and COPD patients?
Absolutely. It's like you saw, physical activity is one of the main recommendation in the COPD patients, non-pharmacological methods also.
This was Dr. Ajita. Now, Dr. Aarti Mehta asking, how do you identify inflammatory pathway?
Right. So, 2-3 things. Ideal is that induce sputum. It's done in one of the centers around the world. We don't do it in India, but the type of sputum gives a lot of information, whether it's a lot of eosinophils or not. That is one. Second is the history. If someone has childhood onset asthma and I'll multiple triggers, family history, I'll know that this is allergic phenotype. IgE sometimes help. Allergen specific IgE also will be able to identify that this is the allergic phenotype. Blood eosinophil, simplest method to identify. And it is important to know that it's not the blood. If you've given the steroids, if patients come to the ER, take the hydrocort, and then next day they go for CBC, the eosinophils will be depleted. So if you are able to do the CBC before you start the systemic steroids in an exacerbation, blood eosinophil gives you good important. Pheno is a very good test that will give you an understanding of the inflammatory phenotype of these patients also. So these are the few ways in which we do it.
Thank you. This question is little longer. 54-year-old female, postmenopausal, no diabetes, hypertension, thyroid, no other issue. Only has tachycardia between 90 to 110 per minute. Osteoporosis, varicose veins, complaints of chest tightness, and always need to clear the throat. ECG, 2D echo, everything is normal. Lot of sneezing. what can be done to this patient further in
Right.
respiratory? Now that we have ruled out cardiac,
Correct.
we do spirometry or what should we do?
So yes, and specifically what you're saying, this frequent throat clearing.
Yeah.
In clinic, even I ask the patient that, do you need to do this? People are doing this year in and year out. This is very commonly a post-nasal drip. So in this particular patient, yes, because it's such a long-standing history, I would get an X-ray done normally yoga, but you do a spirometry. And if the spirometry is also not picking up, and here the symptom is, if breathlessness is a symptom, again goes towards lower airway, but if only this cough, irritant, throat clearing, post nasal drip is also very significant. Sometimes nasal sprays help this patient quite a lot.
Which should be preferred, inhaler or nebulizer in asthma patient?
Inhaler, I think without a doubt. I know this is not the trend. Patients feel nebulizer is temporary. The acceptance, yeah, I know we'll take it for a few days, and a lot of resistance toward acceptance of inhaler. But there are studies where an MDI with a spacer, so not a simple MDI where the technique is incorrect. MDI with a spacer is equivalent to the nebulizer. It is cost effective, less time consuming, easy to get complicated, infected. Only if the patient is not having a good breath hold, extremes of ages, someone with a hand deformity or someone who's bedridden, I would use a nebulizer, but otherwise hands down inhaler, and if possible breath actuated inhalers.
Dr. Arti Mehta asking, are we studying sputum to differentiate asthma and COPD in practice?
Yes, we would love to. I mean, I had recently met one of Indian origin scientists in Toronto, and I think he publishes the maximum work pre-COVID. Even I was scheduled to spend time there. And I mean, their practice is so accurate. Patients are not better, induced with the sputum, see what is the inflammatory pathway and give the targeted therapy. But in India, when we tried to set up these labs, because the patient is made to cough in the thing, no? So we have tried to induce sputum and then tuberculosis, this, that. So in practice in India, currently, no, hopefully in the future, but it's a very good way. But the acceptance is poor all around the world because it's a tedious test to do, is what everybody feels. So UK group doesn't do it. US and Canada, certain centers do it.
Dr. Bhupesh Pandya, can COPD be reversed?
So two things, and this we tell our smoking patients. There are studies where, so if you are in your 20s and you stop smoking, assuming that this is smoking related COPD, you see that the rate of decline, you won't get an improvement in lung function, but the rate of decline will match that of an aging population. So if I'm healthy, non-smoking, still 30 ml per year, my lung function will decline. And a smoker's and a COPD patient's rate of lung function decline will be faster. So whenever you intervene in terms of medication and stopping the trigger, the rate of decline will come close to the healthy individual. Whether you can reverse emphysema, maybe not, but yes, they will be better controlled and symptom wise, they will be much better.
Dr. Mahesh Muthe, can Montelukast be used to prevent asthma? If yes, for what duration?
Again, it's a mast cell stabilizer. So you can't prevent it, because as we saw that mast cell is only one of the ways in which the inflammation happened. You can still have the IL-5 eosinophil mediated. So you do not have Montelukast will not block the degranulation of the eosinophil. So not to prevent asthma, management, and that's why Montelukast works for some, but not for all. So no, in short.
Is Derifilin injection advised in acute attacks?
It has been wiped out of the practice guidelines, international practice guidelines, because no randomized control trial found that to be of benefit. Although having said that, we do have patients who definitely benefit. So COPD patients, but not in my asthmatic unless there is a remodeling. In my asthmatic, I would then rather have them identify, put them on biologics if possible, but not waste too much time. Step 5, you can try, but I wouldn't bank on it.
Dr. Ganatra is saying allergy test reports very often give mites as responsible. How to proceed? Does treatment change or we have to get rid of mites?
In general, it's best to get rid of mites, but like the way in monsoons right now, we are close to the sea, the humidity will be higher. So try to identify surfaces in the house where so I tell them no fur blankets. Kids also do not keep the soft toys and rugs and all in your room. That is one way. Use the dehumidifiers. There is some evidence of that. Air purifiers, no big randomized control trials. So the recommendation is moderate evidence. But HDM, if you get it in allergy test, sublingual or subcutaneous. So immunotherapy, that is desensitized therapy. If the only trigger is the HDM, there is good evidence that your sublingual immunotherapy can work for HDM, house dust mite. So that is one of the indication to give the HDM immunotherapy.
Dr. Ganatra and Dr. Sonam, what I do is if the patient has a vacuum cleaner at home, I ask them to vacuum the mattresses, the corners and everything.
Absolutely.
And this way try to get rid of mites. Dr. Mahesh asking how monsoon triggers asthma in some patients.
So two ways. One, as a season, it can trigger. Like for some people, the pollen season is a trigger. For some, the winter is a trigger. Other thing, humidity level increases. Concomitantly, house dust mite level increases because of the immunity. That is another way it gets triggered. And frequency. So all are viral infections. So which is why even family doctors get a lot of URTIs, because with monsoons, your viral infection also peak. So that becomes another trigger for asthmatics.
Dr. Shalini asking which inhaler is effective in a young asthma patient.
Young pediatric less than 6 years, we will start with a simple steroid inhaler and then add the bronchodilator as and when required. So you'll probably a low dose budesonide and then give the asthalin, levolin, levosalbutamol, salbutamol, SOS. If the frequency increases, then move to a moderate dose ICS. If the patient is then almost 10-12 years, give the ICS-LABA combination.
Dr. Ganatra again, how important is the post-nasal discharge as a trigger of asthma?
Very important, and we see this in practice. And the way to identify is that breathlessness nahi hai, ye wo, the cough is a throaty cough, not very from the chest, not too much wheezing. PFTs or the peak flow meters are not too bad. And then post-nasal drip is a very important symptom.
Dr. Ravindra, injection terbutaline and injection adrenaline, are they recommended for severe asthma cases?
Absolutely severe cases. And these used to be during, when people were inadequately treated. So which is why if in the mild to moderate severity of patients, when you start the anti-inflammatory or the inhaled steroids and not depend too much on the bronchodilator, hopefully such sort of status asthmaticus shouldn't happen. So I'm 8-10 years into practice, and when we talk to our bosses, earlier ICUs used to be full. I'm sure many senior practitioners, ICUs used to be full with asthma exacerbation, which you'll not see today because we have better treatment, and very rarely they will go on the ventilator. The way with NIV, we can manage type 2 respiratory failure better. They get into COPD patients are also getting intubated less and less. And with home NIV, they are not getting hospitalized also that frequently. So very rarely, but we've got better ways to prevent it.
Any medical management of recurrent nasal polyp?
Yes, the way I said that inhaled steroid, the Montelukast, they are the add-on treatment. Very severe case, you'll need oral steroid for the polyps. But identifying, and these biologics have been studied, and some of them are doing good for the nasal polyposis also, if it is allergy mediated. Or even if eosinophil, if you establish that eosinophil, there is nasal pheno also. So biologics will do well.
Dr. Hitesh is asking, can we use Montelukast in pregnancy and lactating mothers?
So yes, you can use Montelukast in pregnancy. Although again, if you see the steps, Montelukast, people prefer to take it because it's a tablet, but it's better still to try manage it with the inhaler and give the oral tablets only when it is required.
And injection of adrenaline, last question, is in resistant asthma as against acute severe asthma.
Yes, so when you're pushed to the corner, you can use it for the bronchospasm. You will give the IV steroid also. It takes about 6 hours to act. Till then, you can give the injection adrenaline, but the idea is to not reach that stage at all.
Thank you very much. Friend, just to tell you that as our tradition, this video will be available on YouTube for eternity. Thank you very much, Dr. Sonam. And again, friends, to inform you, Dr. Sonam is obliging us again next month, 10th of August, for diagnosis of tuberculosis. So please spread the word around. We want a better audience, bigger audience. Thank you very much, Dr. Sonam. No words to thank you. And the interest with which you answered all these questions. Thank you very much.
Most welcome. Good evening, everyone.
There are a lot of thanks. I'm not reading that. I just read the, yeah.
Yes. Thank you.
Thank you, sir. Thank you, ma'am.
Suresh.